And for all of those interested, if you're not able to make it or think this is useful for your colleagues, the link to this recording, this session will be available at the Equally Well website. So I want to welcome everyone to our second Equally Well webinar. Following on from our first one last month with Queensland Health, this one is focusing on older persons' mental health with a strong focus on some of the fantastic stuff that's happening in New South Wales, local health districts and statewide. First, I'd like to acknowledge the traditional owners of the lands on which we're meeting across Australia and pay respect to the elders past, present and emerging. Also acknowledge any international visitors to this webinar and pay respect to the First Nations peoples particularly from Canada and New Zealand. This is such an important and pertinent area. The Royal Commission into Aged Care and also the National Mental Health Pandemic Response Plan all have a very strong focus on the mental health and physical health of older persons living with mental illness. And I think this is going to develop very quickly. So I just think this webinar is such an important webinar for anyone who's thinking about being prepared for what's going to happen in Australia and internationally over the next 6 to 18 months. Just a little bit of housekeeping. We've got 5 presenters today, so we're keeping it all very short and tight. And after each of the presenters, after the first 2 presenters, there'll be a short time for Q&A, and then after the next 3 presenters as well. And then we'll have an extended Q&A session after that. If you hover your mouse down near the bottom of your screen, you'll notice that there's a Q&A box. If you have any questions that you'd like to raise, put those in, and I'm hosting and chairing the session, so I'll moderate those and either present them to the presenters, or the presenters may even respond to them in the Q&A chat box. Also, would also like to mention that with the 5 presenters, we'll each have 7 to 10 minutes each and a few minutes after each. So without further ado, I would like to introduce our first speakers, Dr. Rod McKay and Dr. Kate Jackson. I think it's not too far of a stretch to say these 2 people are some of the most influential people in Australian older persons' mental health. And I don't even think that's arguable, quite frankly. Their leadership in this area, both clinical policy and research over the last decade or 2, and their achievements are significant, and not only their leadership, but the things that they've done and actually implemented and changed systems. Welcome to Rod and Kate, and I'll hand over to you for the first part of this session.
Thank you very much, Russell. I hope we can sort of live up to some of the expectations you're given. With that, I'll just go on to the next slide, John, because as I was thinking about this talk and rethinking about this talk, I was struck by why do we have to have this talk? Because working in older persons' mental health services for now maybe too long, I mean, integrating physical and mental health care has been the core of older persons' mental health services since they were first formed. And the reason for that is fairly obvious. Older people have lots of strengths, but they get greater problems with their physical health as they grow older. And we all know that experience. And yet, somehow, we're not feeling as comfortable now in working with that complexity as we used to be. And maybe that is because as actually more people have grown older, services have grown bigger. We've had new people come into the field, which is fantastic, but something is missing. So the question is, what is missing? Now, if we just go to the next slide, I think one of those things is that somehow we've lost our confidence in working with the complexity of physical and mental health care. And this is not just an Australian problem. These quotes you've got in front of you are from the UK, that people are not confident, clinicians aren't confident working with that complexity as people who are both older with severe mental illness and physical illness, and therefore older people are falling through the gap, and that people aren't clear who should be doing what, And so there's a need both to find ways for us to work together better, and for us also to upskill. How do we build up the knowledge and the skills we need to help older people to be physically well as mentally well? And next slide. And to hopefully state the obvious for everybody who's on the webinar, we also know that people with serious mental illness have got complex physical health needs. And we've got a growing evidence base about the needs. We've got a slower but growing evidence base about what can be done to try to help meet those needs. But importantly, both those needs continue into later life, and fortunately, more people with serious mental illness are now living into later life. And again, maybe that's one of the reasons that we're starting to have more challenges in an area where we previously felt fairly confident with. And the next slide. And I think what is positive, not because it's happening, but because we're starting to recognise, is that the physical health problems of people with serious mental illness as they grow older are under-recognised and under-treated. So despite, and this is work again from the UK, but looking at the assessment and treatment of physical health problems with schizophrenia and then focusing in on older people. And the bottom line is despite knowing the problems, despite the person being older and therefore older people in general accessing healthcare more, there is still way too many people who do not have their problems identified even, and of those who are identified, not enough receive intervention, with really a 50-50 chance of actually receiving an appropriate intervention, which if it was anyone else in the community, we would just think was totally unacceptable. And the next slide. So, why might this be? Well, maybe one of the things, the reasons this is because when we think about people who are both older and have mental illness, they've had reasonably limited attention in practice, in policy development, or in research. And one thing I didn't highlight from the previous slide, but I will mention is maybe one of the reasons for that is despite the people in that study having really what we'd see as totally inadequate access to appropriate care, they were mostly satisfied with their care. And I think that's what maybe one of the issues in terms of why older people with mental illness and physical illness haven't received the focus that they need. And the next slide. So what are we trying to do with that in New South Wales? One thing we have in New South Wales is a process of benchmarking where we come together and we look at a combination of data. We have people in the room to discuss practice, and then we try to look at actually where do we want to take practice. And so one of the focuses, one way we do that is actually a self-audit each year where clinical teams actually look at against standards that they have been involved in setting, how well are they meeting those standards? And most of the news out of that is good, of improving practice, and definitely in some areas of physical health care, that has also been positive. But there have been some standards that have been persistently difficult to actually have a large proportion of services feeling confident that they are achieving. Sometimes some of those have been persistently low. Some have times when services feel they're getting them together, but then they dip down again. And unfortunately, when we had an evaluation of our community model of care, those same challenges came through in what people said to the evaluators. So it was very clear to us, we've got a challenge. What do we do about it? And the next slide. One thing we can do about it is actually hear better from those people who are accessing services. And so if we look at what consumers have said who've accessed mental health services in New South Wales and who are older, then, well, they're actually saying, well, they feel they're getting a reasonable amount of information, which is the key question that is asked in Yes regarding to physical health, around most of the things you would hope that they would receive information about. interesting enough, across the lifespan, there is less information or less reported information being discussed around sexual health. So consumers seem reasonably satisfied with the information they're getting and with services. But unfortunately, that doesn't have to mean there's not a problem, because that actually is quite consistent with the UK study, where despite poor care, people were satisfied. So if we go to the next slide. So it means we have to go back and think about actually what does all this mean for care? I mean, it clearly means that if we think about older people in general, and particularly as they move from, if you like, the young old to the older old, they're going to have increasing physical and mental health comorbidity. And so we have to find ways that we can integrate care. We need to understand, how do we work with the risks and complexities that can come for older people who've also got mental illness? How do we improve our assessment and treatment consistently? It's not about not knowing what we should do, it's how do we actually do it each time? And how do we then look at ourselves, but look at all our partners in terms of what is our attitude to physical health care, our role, our attitude to how we work with others, and actually what is the role, and is the secret to this how we empower older people, and really should put there and those around them to actually advocate for their physical health. And the next slide. And so in 2019, we were looking at, looking back, what do we know and where do we want to go? So we knew that we had an explicit focus on physical health care and policies and our model of care. And we also knew we've had times that in benchmarking we have focused in on physical health care, but we've still got gaps. So what can we do to promote integrated care better? How do we actually build on that measuring and monitoring of practice? And where we came to is, well, do we actually need to do something at a statewide level to try to improve practice? And we thought the answer was, yes, we do need to try and do that. So the question was then how? And the next slide. And so what we looked at is actually how we could try to come together to look at how can we systematically improve physical health care, but in a way that is locally relevant. It's not in any way trying to say, as a state, we can say this is how you do it, but we can help to facilitate. How do you come together to do that? How do we try to drive a systematic drive to action, even though the actions might be different? They're all heading in a direction, the direction being try to improve the physical health of older people with mental illness, and to think about what are the factors that seem likely to increase the probability that action actually will improve health outcomes. Because if we look just at the evidence for older people with mental illness, the evidence isn't strong enough. So what could we do? We need to have specific actions. We actually need to do something. We can start different places, but we need to do something. We need to take the opportunity to actually improve the evidence base as we do something, so that we do know better about where we should put our investment. And we've got to do that together. We'll do it in a way that actually, how do we build up trust at every level, from not just between the clinician, the consumer and their family, between clinicians who are maybe in different silos, between clinicians and policymakers. At every level, we've got to build up that trust so we can work together. And so out of that, we moved into a focused statewide practice improvement, which Kate will now start to talk about.
Thanks, Rod. And John, if we can move to the first slide. Thanks. So look, to address the issues that Rod's identified and to take up that idea of a focused practice improvement effort, we embarked on this statewide older people's mental health, physical health practice improvement project. And this builds on a methodology that we'd used previously for a statewide practice improvement project to promote recovery-oriented practice in older people's mental health services, and that had been used with some success. So the project aims to promote improvements in physical health assessment and care of older people's mental health service consumers. It includes our community and inpatient services across the state. We're seeking practice improvement within older people's mental health services and also through older people's mental health service collaboration with consumers, carers and service partners. And you'll see in some of the presentations that will follow some of the collaboration that we've embarked on. Recognising that the project doesn't have any specific resources attached to it and that local older people's mental health services will need to work with the capacity and the resources and the opportunities that they have, the project uses an opt-in and start where you can approach to progress those local projects. And that also proved successful with our previous statewide practice improvement project, and we've had really good engagement from local health district older people's mental health services across all of New South Wales. We have a number of strategies to support the work that's happening locally. So we have a statewide project steering group providing advice to the project teams. We have targeted literature review, which I'll talk about in a minute, a toolkit of practical resources to support the local project leads, and a range of other strategies. The project does really rely on local leadership and from project champions and supporting managers, and we're really fortunate to have some excellent local project leaders, and you'll hear from a few of those people today. We've also encouraged consumer and carer consultation and collaboration and engagement in project design and planning, and where possible co-design approaches as well. And you'll see that a number of projects are focused on approaches that seek to empower older people around their own physical health care needs. One of the key things that we learned from our previous statewide practice improvement project was that formal evaluation of statewide and local projects and getting findings into the published literature didn't happen except in a few instances. And so given the significant gaps in our knowledge about what actually works in terms of implementation, that is the implementation gap as it's called, we've formed a partnership with Charles Sturt University and a number of other research partners to support rigorous evaluation design and publication of findings and add to the published literature where we're able to. Next slide, thanks, John. So this is an overview of the project methodology. I won't dwell on it too much, but we've established our project steering group that's established in early 2019. All the LHDs, local health districts that is, are establishing or implementing local practice improvement projects, and we're expecting that those should be completed by early to mid next year. We've had some disruptions, obviously, to timeframes from the COVID situation, but we're progressing throughout the state. By mid-2021, we aim to have a statewide project report out and an event to showcase those local and statewide project outcomes. Possibly we might be able to tie in with an Equally Well symposium next year. The challenge then, of course, is to sustain the focus on this area of practice and practice improvement, building on what we've done and what we've learned from the project. Next slide, thanks, John. So the project's built on a range of key partnerships. I've mentioned a couple of those. So Charles Sturt Uni is a partner who's supporting the literature review and providing research and evaluation support for both the statewide and many of the local projects. Our New South Wales Clinical Excellence Commission is supporting the local project planning, helping to ensure that we follow evidence-based quality improvement methods in our local projects. Nearmy and Flourish are both partners for us, and you'll hear from Steve Sutty today from Nearmy. And we've also got a range of other local and statewide project partners. Thanks, John. Next slide. So I have to acknowledge Russell Roberts for these slides. I mentioned we've partnered with CSU for this project, and the project has produced a literature review to support the statewide and local initiatives. I won't go into too much detail, but essentially looking at the international literature over the last 15 years, the review found only 13 studies that specifically relate to the physical health of older people with mental illness and the reported impacts of the programs or interventions on this group in particular. So the research is pretty limited. Next slide, thanks, John. These are the studies that came up in the review. They related to screening, psychosocial and consumer-led approaches, and physical activity. Noting with physical activity that the review found no specific published research on the impact of physical activity programs on the physical health of older people with mental illness, despite the well-documented effects of exercise on older people's physical health, on mental health and balance and cognitive functioning. Next slide, thanks, John. And the literature, this is the literature around integrated and collaborative care. There are a few studies that relate to specifically to older people with mental illness. So the messages really from the literature review are pretty simple. The evidence is if you do something, it helps, and that supports our start where you can approach. There's a lot of research describing the problem, but very little on actual implementation trials, that is highlighting that implementation gap. And this is a field that really needs research, which supports, of course, our efforts to publish the findings of this project. Next slide, thanks, John. So local practice improvement projects that are being progressed under this overall statewide approach are focused in a number of key areas. So we've got 5 local health districts that are pursuing projects around screening, assessment and referral pathways. We've got 5 local health districts that are pursuing projects around empowering consumers to promote their own physical health. And we've got 3 local health districts that are pursuing physical activity or exercise initiatives. And obviously, because there are a number of local projects that are pursuing projects in each particular area, we've also tried to promote collaboration across those research and project teams that are undertaking those similar kinds of projects. Next slide, thanks. To introduce really our next 3 speakers, the theme of the work to date has been that older people with mental illness have different needs from other age groups, but tools and approaches that from those other age groups can be adapted to meet their particular needs. So today we like to profile 3 particular local projects that are being progressed under the umbrella of that statewide practice improvement project. Carmelo Aquilina is going to talk about a South West Sydney local health district project building on the Canadian Fountain of Health resource and leveraging international collaboration. Steve Sutty is going to talk about a NEMI collaboration with a number of local health districts, which is building on the existing NEMI physical health prompt, or health prompt, sorry. Brian Tomney is going to talk about a Northern Sydney local health district project, which is building on and adapting existing work in physical health screening, particularly around metabolic monitoring in adult and older people's mental health services. So over to Russell to introduce the next speakers.
Thanks, Kate. Before we do that, we've got a couple of questions in the question and answer box that you and Rod might be able to address. One of the questions was about the process of getting the older person's experience of service in the YES survey, which is your experience of service survey, for those who are unfamiliar with it.
Kate, if you're happy, I'd be very happy to answer that.
Sure, yeah.
We had a lot of concerns in New South Wales about whether the YES survey would be suitable for older people. And there's a number of reasons you could look at it and think maybe it won't be. But what we actually did was therefore actually got some people to try it with older people. And the bottom line was actually they could use it just as well as younger people. So therefore, we've implemented it just as we have across the lifespan. And just as is across the lifespan, it's not perfect responses, but actually our response rates are similar to the rest of the lifespan, and the data makes sense. So I'd say go for it.
Yeah, and probably just to add to that, so New South Wales has taken an approach across all mental health services to have some specific questions that relate to physical health within the YES survey. So they're New South Wales specific questions. Happy if the person who asked that question, happy to follow up to give you some context around that.
And that might be a good segue into the community of practice as well, and that where we could have the conversations about the processes of getting your jurisdictional government to include, add or include those questions focusing on the physical health of people living with mental illness, and particularly for older people. The other question was about the role of carers. Can you, Rod or Kate, can you talk to us a little bit about that and where that positions, how you position with respect to engaging carers in this program?
Rod, did
I
you?
think there's two levels to that. One is in terms of feedback, and the other is in terms of involvement in the program. And I might speak to the involvement in the program, and then Kate might like to speak to the issue about brand carer surveys. In terms of the involvement in the program, I think it's been really interesting that older persons mental health services have gone, at least in New South Wales, from a very big focus on carers and maybe not enough on the consumer and their empowerment, to swing into a lot more empowerment of the consumer. But I think in that have mostly kept that right focus on the importance of having the family and carer involved. And definitely that I think is the sort of thing that you'll see coming through in the projects. And definitely I think that's a theme that we're seeing.
Thanks, Rod. Yeah, and I guess just to add to that, certainly in terms of carer feedback, we are implementing the CESS, the Consumer Experience, Care Experience of Service in New South Wales, and that will give some feedback. But yes, I'd expect that the local projects would mostly be trying to engage both consumers and carers in their consultation processes. And you might hear a little bit more about that in the project presentations that follow.
Great, thanks Kate and Rod. It's my pleasure to introduce Carmelo. Before I do, just a few housekeeping for those who came in late. There is a Q&A box, and so if you post any questions, there'll be 1 or 2 minutes after each of the presentations to follow, and then hopefully a more extended time at the end of all the presentations for a more broad panel discussion. Also, this session is being recorded and you'll be able to access that later. I think one of the great things about this project is this group just doesn't talk about it, they actually do it. And what we've got now are 3 7 to 10 minute presentations, which are actually talking about clinicians and groups doing it, you know, the reality of implementing change. And it's so consistent with, you know, in Equally Well, we do what we can, where we can, when we can. So I'd like to introduce Dr. Carmelo Aquilina, who's the Clinical Director for the Southwestern Sydney LHD for the older persons mental health services there. So thank you, Carmelo, and over to you.
Thank you. I would like to talk about a project which I became aware of a few years ago at an international conference. Yes, remember those days when we could actually go overseas. And I thought this was probably the most important innovation that Canada has produced after insulin, the cardiac pacemaker, and evidence-based medicine. And it's probably a great apology for Celine Dion. It's called the Fountain of Health Project. It is a project that promotes positive health behavior in older people. And as we will see, it promises to be a clinically useful, achievable, incremental program to promote positive health behaviors in older people. Next slide, please. There it is. We always argue as to whether good health and longevity are due to nature versus nurture. A study in 1998 from Sweden looking at identical twins answered it pretty decisively. 25% of longevity seems to be due to genetics, and 75% is actually due to healthy behavior via epigenetics. So exercise, nutrition, good environment, and emotional health seem to have a greater impact on longevity and good health than genetics. Next slide. However, if we look at what makes us healthy, we actually, next slide, we actually can show that 50% of that is due to healthy behaviors, very little to genetics, and only 10% in terms of actual healthcare. Next slide. But what we spend on being healthy, most of our spending is on medical services. So we spend most of our health dollars on the least effective part of health promotion and health giving behavior. and only 4% of our spending is on healthy behaviors. And the next slide will actually be the reference to that. So this is a paper from 2016. A great deal is known about how to change health-related behavior. And health behavior change interventions can be made part of standard health and social care. Next slide. We need to steer away from information giving and instead empower and motivate individuals to generate their own solutions to their problems. So everything that we need to do needs to move towards individualized health behavior change. Next slide. And current health policy stresses the potential of cumulative small changes in individual behavior to produce significant advancements in population health. And that, I think, is the most telling of the insights that I gained in studying how the Fountain of Health strives to achieve its changes. You may not see much changes in your individual patient, but cumulatively, if we adopt this as a group, we will see lots of changes, not just in older people, but also critically in middle age, where we could possibly see the best impact. So the Fountain of Health, the most attractive thing is that it's a 5-minute intervention. Next slide. It provides clinical tools for primary prevention, help reducing relapse and promoting resilience, and it empowers patients and enables clinicians to give them smart behavior modification tools. Next slide. So the only criteria is that people are over 40 years of age and no dementia. Although we are starting to see some evidence that even people with dementia can benefit from this, and there's a paper just published in the Journal of the American Geriatric Society from an Australian study showing that even people with dementia will show improvement. This has not yet been studied and implemented in the Fountain of Health project. Next slide. So there are 5 areas that we try to promote: social activity, physical activity, mental activity, positive thinking, and mental health promotion. And I'll briefly go over possible interventions in each area. Next slide. For social activity, next slide. The simple things like connecting to friends via phone, email, Skype, physical contact when we can, opening ourselves to new opportunities to meet people, and linking up socially. And there's a lot of evidence for this to be helpful, both in emotional, physical, and cognitive health. Physical activity has probably the best evidence base in terms of physical activity, at least 30 minutes of strenuous exercise a week, ideally more, incorporating that into not just your daily routine, but also to try and take on new exercises and new ways of achieving strenuous physical activity. Next slide, please. Positive thinking. Next slide. Certainly, the effects of mindfulness and meditation-like activities like gratitude list, enhanced problem solving, strengths assessment, and self-compassion actually promote a positive outlook in life. And positive outlook is certainly related to a better outcomes in healthcare, but also good outcomes in staying healthy and living longer. Mental activity, we know, is as important as physical activity to stimulate brain reserve and delay the onset of dementia. And there are things that could be done, including book clubs, courses, classes, changing routine, even using a computer to stimulate interest. Although I think we underestimate how powerful it is. Next slide. mental health promotion really is stress management techniques, deep breathing, relaxation, sleep. It overlaps with positive thinking, but actually promoting activities that minimize the chance of lapsing into unhealthy thinking patterns. So I'll tell you how all this works. Next slide. There are the first stage at the first encounter. There's an introduction and 3 things are done. Next slide. The clinician has already read the 3 steps. Next slide. There is also some understanding that we are setting SMART goals, specific, measurable, action-oriented, realistic, and certainly achievable within a certain time limit. And the clinician also has, next slide, scripts for navigating a negative response, which is the red light, a maybe, I may, or possibly, which is a yellow light response, and building on a green light response. Next slide. So then 3 things are done. Next slide. We do a health and resilience pre-intervention questionnaire, rating ourselves on successful aging, how much they're interested in trying new things, how much they're rating themselves in terms of seeking mental health, being physically active and socially connected. Next, and a take-home goal sheet. So people are invited to take on a sheet which reinforces something that they choose to do. So this is something that the Australian group is trying to build on, and I'll talk about it later. But at the point of that, a goal is set. So they set a baseline goal, and they set a time by which to achieve that. And it doesn't need to be massive. It needs to be something specific. And even the very fact of thinking about how to improve people's healthy behavior, I think is useful in its own right. Next slide. So at the second encounter, and this can be repeated multiple times. Next slide. We ask them to fill in a separate post-intervention questionnaire, and this compares it to the pre-intervention questionnaire. Next slide. And we look at how well the goal has been attained and how well or not people feel. So once this is done, each intervention, so the first encounter and second encounter, we're not talking about clinician training. It takes between 5 to 10 minutes. My colleagues who have started using it say that as long as you don't introduce using a health app, which is available to try and rank and support the healthy behavior, then everything is achievable in 5-10 minutes. If you try to explain a health app to most people in our group, it takes far longer to try and explain that, and even longer to try and get them to use smartphones. Next slide, please. The results from Canada, which we can talk about, is that every member of the multidisciplinary team can use it. Next slide. And people rate it as being very easy, time efficient, and acceptable to patient. Now, on the basis of the goals that the Canadians have set out in terms of self-rating, most people exceed or had full or partial attainment of their health goal within 1 month. I don't have any results for longer term use. So next step. So the next steps we're on track. We're piloting the unmodified Canadian intervention in one of our teams. We are using a resource booklet which actually builds on the information in the take-home goal sheet and gives a lot more information on how to feel, live, and stay well. And we're building that, we're writing that in combination with Canadians, because I don't think it's going to be primarily a Canadian specific resource, but we are going to include local New South Wales resources and links that people in Australia or New South Wales at least can use. So we're going to use the tools unmodified for 10 to 20 patient pair encounters. Next slide. We're going to start putting the information in a database that's provided by Canada, obviously anonymized, and part of the agreement with Canada is that we'll send them anonymized pre and post intervention sheets. Within the next 4 to 6 months, we will have a video training session run by the Fountain of Health team, where we can allow the scripts that the Canadians have provided to be reviewed and perhaps modified. I have to call out Professor Kerry Lee Cassidy in Canada, who has graciously accepted to provide a training session by video on Australian time, which is about 4 a.m. in Canada at that time. So that's above and beyond the call of duty. And we are exploring with collaborators in the University of Manchester the possibility of having a cross-validation exercise with a separate well-being assessment. But that's gone pretty quiet for the time being. It's not our core aim, but we're happy to tag on if it's feasible and acceptable any cross-validation exercise for that. So that's our plan. I think if we can implement this and make it relevant to people in New South Wales, we will be able to introduce a very short, acceptable, effective, long-term strategy to promote healthy behavior in people in our cohort. The Canadians are piloting an intervention that can be done by video link, and they're also well advanced into promoting the same approach with students. But we're lucky to be supported in trying to roll this out with our patient group. I'm happy to answer any questions as moderated by Russell.
Yes, Kamala, we've got a couple of questions here. One is from one of our colleagues at Charles Sturt Uni, Professor Oliver Burmeister, and it's in the chat box, and it's about the goals that older people set. Oliver was saying that in their work, people tend to focus more on relationships as they become older. Is this reflected in your experience?
Yes, social connections and relationships are certainly one of the 5 goals, and it would be fairly easy and certainly, I think, mentally quite good for people to maintain and enhance their social connectedness. We know the research in terms of physical health and emotional well-being from being socially connected, and certainly from my point of view as being interested in dementia prevention, I think this is certainly, there's strong evidence, especially from the Netherlands, and how effective this can be in building up brain reserve. So yes.
The other question that someone's posted, which I think is probably in a lot of people's minds, is how available is this resource with the Canadians? Is this something that people in other districts and other states and territories might be able to make contact and access? Can you talk to us a little bit about that?
Absolutely. Professor Cassidy is delighted that this spreads like a Celine Dion song to everyone's minds. And we're not being charged any fees for use. They are quite happy to try and help us work through whether or not the scripts need to be modified for mental health clients. We are building up resource that can be given to supplement the goal sheets for patients, and that is although we have a 20-page booklet, I can only show the cover at this point because it's still very much in draft form. And that can be adopted with local information on all of the 5 aims. And I'm actually thinking that we may also start working with Professor Cassidy to produce a multidisciplinary resource booklet giving some bit of the scientific background for all the interventions here. So we're still trying this out. I think that the key advantage to this is that it doesn't take up a lot of time, and it can be incorporated within routine health encounters. It doesn't scare people by trying to get them to run a half marathon in 6 months, but builds up on small incremental change. And I think the effect that I think is very hard to see, but I think we need to try it anyway, is that small changes across a lot of people over time will translate into better health outcomes. I'm happy to answer questions separately if questions are sent by email, and I would urge people to Google Fountain of Health Canada. There's a website with lots of resources, including videos, which show you how an intervention is done and some background information. And the last thing I want to say is that I'm dying to ask Professor Cassidy why the Fountain of Health logo looks like the Canada Dry logo. That probably ages me quite a lot there in knowing it.
Thanks, Camilla. And so when you get that, we'll post that up. Now, everyone, Camilla has another commitment, so it's going to have to leave probably in 10 or 15 minutes. But I think there is an opportunity in the Q&A if you want to. He's able to respond.
I'll try to hang on. Thank you.
Email just for a few minutes, etc. Just once again, a little bit of housekeeping. This is a really great opportunity to talk about the community of practice. I'm going to have a go, Lee Cobb, to see if we can do a Zoom poll. So have a bit of a 1 minute stretch. We're 45 minutes through a 1.5 hour session. And it'd be just great if we can get this up, Lee, somehow, or to do the Zoom poll. This is always a challenge, and I'm a bit worried about this, to find out if we can find where people are from. Okay, so hopefully on your screens come up a attendee location poll, and we've just got every jurisdiction in Australia, but also another checkbox for anyone who's coming in from overseas. While people are doing that, I do, and of course would love to acknowledge and need to acknowledge the colleagues at Charles Sturt Uni, particularly Christy Robson, and Suzanne McLaren and Jack Cannon, who participated in doing the work with that literature review. And also just flag, with the Equally Well approach for collaboration, that there are a number of partnerships between the local health districts in New South Wales and the universities, mostly with CSU, but we are also partnering with the University of New South Wales, with our good friends there, and some good friends at University of Newcastle as well. So in the spirit of collaboration and collective effort, and these projects are at various stages of development, mostly very early, and it's a partnership between a university and a frontline clinical service where, both bring something great to that partnership. Us university academics want to publish, but don't have the capacity, and it's hard to get the contact. But so do the clinicians, but they often don't have the time to do the ethics committees and the writing and all the lit reviews. So if you're interested in that, just send us a note through to inquiries at Equally Well. Now, Lee, I'm just wondering whether we can get the results of that poll up. Thanks, Lee. So we've got quite a few people from New South Wales and Queensland and Victoria and Tasmania. So that's a very strong New South Wales contingent and Queensland contingent, Victoria contingent. And I did need to acknowledge our friends in Victoria. They're also doing some great work. There's so much great work happening in the different jurisdictions that we really, it's really exciting. And we'll get an opportunity to share some more of that. Right, thanks, Lee. We'll move on to our next presentation. I hope people had a moment to stretch and have a bit of a mental break. Our next presentation is from Nehemiah National, one of our great partners with Equally Well that's been partnering with Equally Well since before its conception in 2015, really driving and supporting this, and that contribution and perseverance and commitment has been unwavering over that last 5 years. And I know there's Vicky Langan on the Q&A, but today we've got Steve Suri from Nehemiah National. He's a regional manager for New South Wales metro area, one of the metro areas in Liverpool, and is leading across all of Nehemiah, and is going to talk to us about some of the work they're doing. So over to you, Stephen.
Thanks, Russell. So yeah, today I'm going to be talking about Nehemiah National's Health Prompt and the work that we're going to be undertaking to develop an older person's health prompt. Just for those who aren't familiar with Nehemiah, I'll just do the quick elevator pitch introduction for what Nehemiah is. So Nehemiah is a national mental health NGO, started in Melbourne about 30 years ago, and now we're operating across 5 states. We see about 8,000 consumers, give or take, each year. I guess the core business of Nehemiah is psychosocial mental health support in the community. We also have some subacute services, youth residential services. In New South Wales, we also have a big focus on homelessness services and doing assertive outreach for rough sleepers, as well as some other homelessness work. So yeah, I'll just go into a bit of background about the health prompt for those who aren't familiar with it. So Nehemiah started developing the health prompt in 2010 as a result of the increasing evidence and recognition of the links between physical and mental health, and also as a practice-based response to the increased rates of morbidity and mortality experienced by people with a mental illness. After undertaking a significant amount of research, Nehemiah staff, consumers and stakeholders co-designed the physical health prompt specifically for Nehemiah consumers. And what was really important in that was that it reflected a holistic approach to healthcare. It promoted a sense of empowerment among consumers. It reflected the national standards around physical health, and it reflected Nehemiah's understanding of the critical link between physical health and mental health. So the health prompt is a physical health screening resource, and it's designed to reflect a strengths-based approach, a recovery-oriented approach, and also a holistic approach. And so how it works is the health prompt consists of 28 questions, and that elicits a yes, no, or an NA answer, as well as a body chart where people can indicate parts or places on their body where they're concerned about or they're feeling pain or what have you. The prompt is designed in such a way that any no answer is a prompt to have that area checked by a health professional. So for example, one of the questions is, have you had your blood pressure checked in the last 6 months? So if you answer no to that, that's the prompt for you to go to your GP and get your blood pressure checked, as well as any of the other no answers that have come up whilst completing the prompt. So typically when people complete their first health prompt, there's a lot more no answers than yes answers. But as people complete more prompts in time, that typically changes and you start to see more yes answers as they're getting more of those areas checked and monitored. So building on what was already existing in the community and leveraging on the work that a number of other organisations had already undertaken, the health prompt questions have been drawn up from existing health information and resources. And they're including the 1-minute health check, the Rethink health check, the service coordination tool templates, which they were piloted in Victoria, Australian alcohol guidelines, and the Go for 2 and 5 campaign. So to sit alongside the health prompt and support the implementation, Nehemiah also developed a health prompt information and practice guideline, and that has been designed to support staff with information on how to use the health prompt, providing follow-up with consumers, incorporating the health prompt into their current practice, and also how to use the health prompt when working with diversity. So next slide, John, please. So health literacy. So there's a lot of information out there about health literacy. From a Nehemiah perspective, we look at health literacy as a way of using the health prompt and aiming to increase the overall health literacy by improving the self-management of physical health, increasing the regularity and quality of physical health checks, individual awareness of physical health issues and the health check processes, increasing confidence of staff in providing information and interventions, and sort of enhancing referral pathways and community links to physical health, nutrition, and emotional and psychological support services. Another benefit of completing the health prompt with consumers and collecting data is that you get to understand the needs of the client group in so much as what the highest rated answers are and where follow-up is required. So as Russell said, Vicky is watching on today. So Vicky's our New South Wales Health and Wellbeing Manager, and she works with the health promotion team. So they've used health prompt data to understand where the effort needs to be in developing information and interventions. So it's really useful when you see that your highest rated no answer, for example, could be something like dental. Have you had your dental checkup? That was a big thing for us a few years ago, where we noticed that was a massive trend. So Vicky and the team did a lot of work in opening up some pathways for people to go and get that work done, partnering with dental associations and dentists, and being able to get people in for free dental checkups. It made a big difference to people. I'm also aware that Vicky's presenting next week in the webinar, so she will talk in more detail about the work she's done as part of the health promotion framework and get into some of the nitty-gritty about some of those projects, so I don't want to steal any more of her thunder. Next slide, please, John. So NEMI has done some health prompt adaptations in the past, and so NEMI has adapted the health prompt to support a number of diverse client groups. Currently, we have health prompts that has been translated into Auslan, and that's on YouTube. There's a link on the slide down the bottom there. It's also been translated into Mandarin and Somali. It's been adapted. We've adapted the health prompt into a pictorial version for people with lower literacy levels. We've adapted the health prompt for a youth cohort as a result of feedback from clients in our youth residential services. And we also have the health prompt app. So one of the key reasons for doing these adaptations came from the understanding that just delivering people information doesn't always lead to an increase in health literacy, and that the information needs to be provided in a manner that is pitched to the right level and supported. So the Auslan health prompt is a good example, as the deaf community, like so many other marginalised communities, experience some dire health outcomes, particularly when you take into account issues such as intersectionality with comorbid conditions, accessing information, especially when the literacy levels can be quite low and translators are not always available or as widely used as they could be or should be. So providing the health prompt and working through the questions with hearing impaired consumers using the YouTube videos, we were able to support a much better engagement between those consumers and their GPs, so that they were able to have a more holistic understanding of their health. It changed their experience from an activity that happened around them to one that included them and could ultimately be led and influenced by them. So it was much more meaningful. Similarly, the pictorial health prompt that began with the ELPIS project, which was a capacity building project working with residents from licensed boarding houses, and that was about doing some preparation work for the NDIS. So as a direct result of working face-to-face with those individuals, an emerging need was found in relation to building their capacity around managing their own physical health. And in that particular context, 65% of those living in the boarding house setting had lower literacy levels. So hence they could not get what they required from the standard health prompt questionnaire, because it is quite a language heavy document. So the health and wellbeing team and the ELPIS team worked with boarding house residents and some other stakeholders, and together developed a more appropriate way of communicating the message around their physical health, and that's how they came up with the pictorial physical health prompt, which is a great resource. Next slide, please, John. So NEMI has commenced a co-design process to develop an older person's health prompt as part of the older person's mental health, physical health practice improvement project. So that's a big mouthful, that one. This is important work, as we've heard earlier, that people experiencing mental health issues have changing needs when it comes to physical health, and that this continues to change as people age. So NEMI has a consumer participation framework that includes guidelines on how to develop and facilitate a co-design process. And it is important to us that we stick to these co-design principles because we really want to balance and prioritise the consumer voice and views with that of the professionals in the sector and the national standards. So some of the simple ways we've enacted these principles to date are: we pay consumers for their time and expertise, and that includes time for reading and preparation. We're ensuring the working group is balanced, so having the same number of staff and professionals as consumers on the working group. Ensuring everyone has access to the same information at the same time, and where people need some extra support, they receive it so that they can, if they need help to understand it or they need to ask questions and clarify things, we make time for that. The working group meetings are also held in a space that suits all members of the working group. So that's not always the office meeting room, and it has to cater to people's individual needs as well. So we'll do that bit of work.
Steve, I'm just going to give you a bit of a time call because there's a number of questions that I think people are dying for you to answer as well.
Okay.
So yep.
Another minute, Russell. So by undertaking the co-design process, we aim to develop a tool that can support people to access health services that meet their needs, and also improve health literacy. So that'll be through the regularity and quality of health checks, individual awareness of the physical health issues, having self-management and self-efficacy of their physical health, increasing the confidence of staff in doing that, and also increasing those referral links and community links to those services. So in terms of where to from here, what we're going to be doing is Vicky has convened the working group again, consisting of staff and consumers, and they have completed a review of the current health prompts and discussed and agreed the scope of the project. We're in the process of reconvening that group, and that'll be a regroup and a refresh, and we'll be collating the feedback that to be included in the older person's health prompt, but also looking at what needs to be excluded. From this feedback, a questionnaire version will be developed, and that will be piloted in late 2020 across NEMI services and our LHD partners. So from there, in 2021, we will seek feedback from the pilot sites regarding the prompt and looking at the key areas. How are the questions worded? Are people happy with them? And then how can the information be presented? And then we'll take all that feedback back and we'll look at how do we present then that health prompt for use. And then we're also working with CSU to do the research and evaluation piece. So we'll be looking at things like accessibility, acceptability, the impact of using the prompt. Does it do its job and support autonomy and self-efficacy? And also the action arising from the tool. So, thanks, Russell. Do you want to go to the questions?
Yes, thanks, Steve. I mean, it's generated, sorry to hurry you up, but it's generated
right.
quite a few interesting comments and questions. And I think one of the things you highlight is the importance of anything we do has to be acceptable and useful for consumers, but also the clinicians and the carers and supporters who are involved in that. So it's such an important part. No point having the greatest tool if nobody uses it. So one of the questions, though, was has the health prompt been given to clients to fill out on their own rather than with the worker interviewing them? And if so, which appeared to be sort of more effective or more acceptable?
Yeah, so the health prompt, typically when it's done in paper version, just on the traditional, the 28 question document, it's a carbon copy document. So they fill it out on their own and we'll keep one copy for our records and they take their copy, and that information then sits with them, and then they can take it to their GP. If they want support to go to their GP, their support worker can go with them. If they want support filling out the health prompt, the support worker can do that with them. Yeah, usually people are pretty good at telling us how they want support around the health prompt and what support they want. So we take it from them.
The other question was about culturally and linguistically diverse communities. Tell us about its accessibility and availability for people who don't have English as a first language.
Yeah, so that's where we worked with significant groups of people where we've had to do a translation, so Mandarin and Somali. I believe the Somali one came out of Melbourne. Yeah, we'll do that bit of work and get some health translators in to translate that document. I haven't been involved with that process, so I'd be keen to understand how that went, because some of the questions are very carefully worded so that the no answer is the prompt to go and get the health check, as opposed to the yes answer. So I know when I was involved in the Ausland health prompt, and that was there was quite a bit of finessing around how do we ask a question that makes sense that also fits with that outcome. So yeah.
And the final question, because I'll make sure we have time for Brian, and it's a critical one really, is once it's been completed, what's the process in making sure that the referrals are made and looking, you know, that the progress in actually improving people's health literacy and outcomes?
Yeah, it's a very good question. So yeah, the information doesn't sit in the health prompt and put the health prompt away. It's the health prompt is the tool that prompts you to take action. So then I think Vicky put a comment up there before about NEMA's use of the collaborative recovery model. So support workers will work with clients to develop their goals, to develop their actions that they want to take as a result, and then that information will then sit with that I guess care plan, for lack of a better term, or action plan, and then they go to their GP and they will go, and that's where that work actually happens. So the health prompt is literally just the prompt to say, yes, I need to have my blood pressure checked. And then from there, the doctor will obviously have their record saying, yep, 6 months ago we did your blood pressure, 6 months, now we need to do it again. And as we go, the consumer's also learning about the regularity of those checks and what they need to do. And if there's something that comes up as a result of those checks, accessing medication or accessing information, sorry, not just medication, but information about things they can do to manage those issues as they arise.
Great. All right. Well, thanks, Stephen. And really, we're looking forward to our next month's presentation. Don't worry, Vicky, it's not next week. It's actually next month.
Next month.
And with Jade Ryle from Flourish. It's sort of a joint NGO presentation with really practical hands-on tools. We're going to have to keep moving. Stephen, there's another question in the Q&A, but you can probably just answer that and type the answer in that while we have Brian's presentation.
Sure.
So our next presentation is from North Sydney LHD, and Brian Tomney is the clinical nurse consultant for older persons' mental health in the North Sydney LHD. So thank you, Stephen, and over to you, Brian.
Thank you, Russell. Yeah, so next slide, please, John. So just to give you a bit of background about the North Sydney Older Persons Community Mental Health Team. So the team serves a population of almost 1 million people. It covers quite a wide and diverse area of Sydney, running from some parts of the CBD and going as far north as the Hawkesbury River. While residents of North Sydney compare quite favourably on most socio-economic and health status indicators with the rest of New South Wales, there are some challenges. North Sydney has the highest population of residents aged 85 years or over of all the New South Wales LHDs, and in quite a few of the areas of the LHD that population is growing. The North Sydney Community Older Persons Mental Health Team is made up of 4 multidisciplinary teams distributed around the LHD. Strategic governance of the service comes under the Older Persons Programme Manager, while the individual services are under the operational management of the respective area service directors. 3 of the community teams fall under the governance of mental health, drug and alcohol, while one team reports to the aged care service. So as you can imagine, that quite complex governance system can present some challenges. The aim of our project, sorry, next slide, John. So the aim of our project is that by the 31st of December 2020, 75% of all Northern Sydney community older persons clients will have had a metabolic screening assessment done. So the metabolic screening assessment is that they'll have waist circumference measured, weight and height measured, a measurement of blood pressure, and have the appropriate blood tests done. So cholesterol, triglycerides, blood glucose, and liver functions tests. So we did an audit in early March 2020 that showed in the 4 community teams, only between less than 1% and 30% of consumers had a metabolic screening assessment completed. So based on this and a review of the literature provided by the statewide project team, it was decided by the project working group that increasing the rate of metabolic screening for our consumers would provide a clear, measurable, and beneficial project objective. Next slide, please, John. So a project working group was initially formed at the end of 2019 with representatives from each of the 4 community teams and from the Northern Sydney executive team. Then in June 2020, very fortunately for us, we had additional older persons mental health service growth funding, and were able to recruit 3 senior mental health clinicians to our 3 mental health and drug and alcohol teams, as well as a part-time exercise physiologist to work across these 3 teams. So these clinicians were actually employed mainly to focus on physical health and well-being of our consumers, and they were added to the project working team. The project working team meets monthly, with most people still being able to attend in person. At the beginning of the year, myself and another member of the team were able to attend a 2-day Clinical Excellence Commission Improvement Science workshop, and it was decided that we'd follow the methodology suggested in the workshop. Next slide, please, John. So this is the project driver diagram for showing our progress so far. So this is a visual tool that was suggested in the CEC workshop that just helps to systematically plan and structure the project. So following the CEC methodology, to complete the diagram, once the project's aim had been decided, the working group carried out a brainstorming and affinity diagram exercise to identify the root causes of the low completion rates of metabolic screening in the teams. So the way that's done is working in silence. The group wrote the causes of the problem on post-it notes, and then these were grouped and reformatted into actions that could be pursued by the project teams. So category headings were actually, they made up the primary drivers, while statements under each heading formed the secondary drivers, as you can see on the driver diagram on the screen. I've actually found using the driver diagram or compiling it and updating the driver diagram to be really quite helpful in steering the project. And at each of our monthly meetings, the project group monthly meetings, we use the driver diagram as a live document just to review progress to date and agree our planned interventions for the future. So next slide, John. And probably go on to the next slide after that. So from the driver diagram, we've actually managed to already identify some interventions that we've started to pursue. First of these is Wellness on Wheels. So that provides clinicians with equipment and resources just to enable them to carry out physical health monitoring at the consumer's home. So all the equipment and resources is gathered up into a trolley that can be taken on visits. And it's well understood that with our consumer population, mobility issues sometimes make it hard to get to clinics. Next slide, please, John. So another intervention we've started to pursue is just providing our consumers with information and education about some of the resources that are on offer. So this one's referring to assessments and potentially individual exercise programs that can be provided by our exercise physiologist. Next slide, please, John. And then another part of another one of our interventions is to start to look at the just the processes around physical health assessments and interventions in each of our 4 teams. So this is just a flow chart done by one of the teams. So we'll spend some time comparing these processes and just trying to ensure that physical health issues and physical health assessments are considered and discussed regularly by the team. And I think going through this process quite rigorously will actually be quite an important part of making any improvements sustainable into the future. So next slide, please, John. So looking at results obtained so far, really we've only been going, because of COVID interruptions, probably 2 or 3 months, and we've already started to see just an increase in the rate of metabolic monitoring that we've managed to do on each of the teams. So you can see there that RIDE have gone from basically a baseline of 0% up to around about 30%. The Hornsby team have gone from 20% to around 40%. And next slide, please, John. And our Northern Beaches team that did have a higher starting point, there has been an increase already, but not so much so far. And they're still going through some work to look at their processes around physical health. So we're hoping that we'll see some more improvement there. So some improvement already, but still quite a long way to go. Next slide, please, John. So the challenges faced by the project so far, as I said, we had basically a 3-month delay because of COVID-19, and some staff and some of the community teams are still working from homes for some of the time. We've already had some staff movements that's meant some changes in our project working party. One difficulty we've faced is uncertainty around current policy and procedures for physical health assessments. There is a lot of, the actual requirements for physical health assessments are contained in a lot of different policies, and there's lots of different guidelines and recommendations around how and where things are documented. So clinicians find that quite confusing. A lack of resources for physical health assessment, so we've had to spend some time and effort acquiring additional resources, blood pressure monitors, etc. for the teams, and just finding clinic space can be difficult. Some uncertainty around the medical legal implications of doing regular physical health monitoring. Just what happens when we find observations of concern for our consumers? What do we do with the results? How should we escalate where we're worried about something? There's more work to do there, and that's becoming the subject of wider discussion in the LHD as well. Some uncertainty over referral pathways, so just access to dietitians, physiotherapists, etc. We've had basically no consumer involvement in the project so far, but hopefully that's going to be, we're going to be able to resolve that over the next few weeks. We've managed to recruit some consumer support workers. And then there's some blurring of the boundary between the physical health care improvement project and our newly appointed senior mental health clinicians. So in some of the teams, because we have the senior mental health clinicians, some people think that physical health assessment is exclusively their domain now. So that's been a bit of a complication. Next slide, please, Russell. So where do we go to from here? So continuing to raise physical health issues as routine and consumer assessments, multidisciplinary routine case reviews and in care planning. So we'll continue to look at the processes around that. Just further engagement of staff in terms of education, information, and physical health and well-being assessments. Continue to speak to GPs about the project and communicate results, find the best way to communicate the results of our physical health assessments to them. Further discussion around procedures for recording and communicating results of the health assessments we do, and looking further into the escalation procedures, and just ensuring consumer involvement in the project. As I said, we've recently recruited some consumer workers, so hopefully we'll be able to get them involved in the project. And we will look to get all our information and leaflets reviewed by and go through our consumer tick approval process. So there will be some involvement going forward. And I'm happy to take any questions.
Thanks, Brian. One of the questions, and I think you've answered it, but I'll just give you a chance to elaborate on it, was about in the health and wellness education program, do you have people with lived experience giving their recovery stories?
As I said, there has been limited involvement so far, but it's something we intend to, with the recruitment of the consumer support workers, which actually only happened last week. So they'll be starting in the next few weeks, so that will certainly help in that. All the leaflets will go through a consumer tick approval process. And one of the things we've discussed in evaluating the project is certainly to have our clinicians gather some patient stories and talk about how the process has actually led to concrete results. So that's certainly part of our plan for evaluation.
Thanks, Brian. I might open it up to all of the panel now. So if you could enable your mics, and while you're doing that, there's been a few questions, and yes, the slides and the presentation and the recording will all be available on the website probably later this afternoon. In the chat box in a minute, Lee will put the link to where you can find those. There's some other questions about the resources. A number of them we already have on the website, but pending permission from the presenters, we can also download them. If you go to the equallyWell.org.au website under resources for professionals and supporting others, we'll place those other resources there. One of the questions to the whole panel though is, and I'll just open it up for any other questions that might come live, but summarising all of this, for people who are interested in improving the physical health of older people living with mental illness, what would be your sort of the number one practical tip in terms of trying to make an impact?
I'm happy to go first, Russell, if you like.
Thanks, Steve.
So I think the biggest thing that I've noticed in my time working with people is that relationship is key. So getting people in touch with people that they trust, people that they're happy to talk to and go and speak to and ask questions, people that make them feel comfortable. And just working with them to get in touch with as many of those people as they can that know about the area that they're concerned about or they want to improve or whatever. Yeah.
Great point. And Kate, what would be your reflection on this?
Yeah, look, I mean, thinking from the sort of systemic perspective, I guess, is start with engaging people in a conversation about the problem and the potential solutions, and then what might flow from that is action So, you know, try and, whatever the area, promote some action, and also try and promote evaluation of that action. And that's what's come out from our experience so far in this work, and also from the literature review. So those would be my thoughts.
And Brian, I might ask you next, and then Rod ask you to sort of then spend 2 or 3 minutes responding to that, and then summarising the whole session, if you could. So, Brian, what would be your one short practical tip?
I think it's trying to get an integrated approach with everyone involved in the person's care working together. We're trying to, and hopefully this will be facilitated more with the senior mental health clinicians. It's trying to involve GPs, our multidisciplinary team being more involved in physical health care, and working closely with the consumer and carers to try and improve outcomes.
Okay, thanks, Brian. And Rod, could I ask you to sort of summarise the session and bring it together for us? Thanks.
I think that the key message I'd have is to start where you can. I think that for too long we've been focused on trying to find the right answers, and actually what we need to do is find an answer we can act on now, and that answer should be linked to some evidence. But there is lots of bits of evidence out there that we can start working from. Once we start working on them, then we can build the evidence. And in particular, there's lots of evidence for what works in older people. Is, you know, building evidence of what works for people with mental illness. Start with either of those things, and then let's build that evidence for actually what works for older people with mental illness. And I think that's what we're seeing in the projects you've heard today. You've seen that you know, in quite different spaces, people have been willing to actually start with something that is important, something that's relevant to their local team, and something their local team or their service feels that they can take on. And they're each then reaching out to partners, whether it be in terms of clinical, the partnership between the consumer, the family, and clinicians, and then as Nima has shown, the important role of community managed organisations. But the key message, I think, is start.
Yeah, thanks, Rod. And I think that's that was evidenced also in the literature review. It's whether it was screening, psychosocial, consumer engagement, or integrated care, all of those things, if you had a go, seem to make a difference and improve that. I'm just conscious of time. Now, just notice in the chat box, Lee has put the link there to the recordings, and that will be live probably in the next hour or two. And also just to flag that there will be a link to a survey. We really would like to improve these and tailor them to suit all of those in the community who are interested in improving the physical health of people living with mental illness. So please take some time. It only takes a minute. There's a Survey Monkey. A minute or two to complete that survey, and we will definitely act on that. I would especially like to thank all of those people who have so freely given of a lot of their time to present this webinar. Dr. Rod McKay, Dr. Kate Jackson, Dr. Carmelo Aquilina, Mr. Stephen Sutty, and Mr. Brian Toomey. And we really appreciate the effort and understand the amount of time and commitment for this. And also, I take the opportunity to applaud and acknowledge you in the great work that you're doing and the impact that you're making improving the physical health of people living with mental illness. So thank you on behalf of Equally Well, the collective, and thank you for all of those folk and participants who attended. And we look forward to seeing you at our next webinar on the 27th of October. Thanks, everyone.
Thanks, Russell.
Thank you.
Thank you all.